This takes us to the cardiovascular system, the heart, part 3 of 3. When we look at this slide, and particularly focus on the two pictures at the bottom of the slide, you'll notice that you're looking at a view of the heart between the atria and the ventricles. So you're actually looking from top down on the ventricles, and this is where you can see the different valves that are between the atria and the ventricles, as well as the valves between the ventricles and the aorta, and the ventricles between the pulmonic trunk or main pulmonic artery. So here's that pulmonic trunk. I did it in blue because that blood is not oxygenated as much as it is in the aorta. So here is the aortic valve. We've got the pulmonic valve, and then the aortic valve, and then down below we've got the tricuspid valve and the mitral valve. Sorry about my arrows, they're not the best. Okay, so the term stenosis refers to a hardening or narrowing of a structure. I just want to plant that in your head as we discuss what can happen when we have different disorders that involve the valves. So a murmur is defined as an unusual sound of whooshing or turbulence that occurs when the valve doesn't close properly and a little bit of blood kind of whooshes around the valve as it's closing, and that's the definition of a murmur. So murmurs are actually somewhat common in children because their valves are not as used to opening and closing as people are as they grow up. Now, not all children have heart murmurs, but it's not an uncommon thing, and most children grow out of heart murmurs. Mitral valve prolapse can occur when part of the valve kind of balloons out and falls or balloons into an area where it's not supposed to go. So that's what a prolapse is when something kind of collapses and falls through. And mitral valves can prolapse, and that means that they're not going to close properly, and that can cause a clicking sound. Now we're going to go back to that term stenosis, which means a hardening or narrowing, and mitral valve stenosis means that the mitral valve has become narrow and or hardened, and that restricts the amount of blood that can go between the left atrium and the left ventricle, and that makes the heart have to work harder. And aortic sclerosis can occur when the aortic valve between the left ventricle and the aorta becomes hardened or narrowed or stiffened, and again that means the left ventricle has to work harder to get blood through there. The chart at the top is really neat because it shows us heart sounds when they occur, and it also shows the different pressures that build up through the heart when it goes through its cycle. So let's look at the heart sounds first. We've got the lub that is going to occur in correlation with the atrioventricular valves closing. That's the lub. And then the second heart sound, known as the dub, actually occurs when the semilunar valves close. So it's AV semilunar, lub, dub, dub. And sometimes you can have additional heart sounds. There's a whole litany of different things that can occur, so we may be looking at that in a future slide. So let's take a look at the pressure next, because I think this is really interesting. You'll notice that atrial pressure is denoted in yellow on this chart, and we're just going to focus on that for a second. You'll notice over here how atrial pressure builds and then decreases before the AV valves close. And what's happening is blood is coming back into the atria, and as they fill up, the pressure builds, but remember that the buildup of pressure in the atria is going to cause the AV valves to open, and 70% of the blood is going to flow from the atria through those valves into the ventricles. And then the atria will contract to eject the remaining blood, and after the atria have contracted, you'll notice that as that happens, the pressure in the atria falls, and then the AV valves close. And again, the closing of the AV valves is when that first heart sound occurs. Now, once the AV valves are closed, the ventricles are going to start to contract. And so there's two things. We've got this increase in blood volume in the ventricles, so that builds up pressure. And then the ventricles are going to start to contract as well, and that builds up pressure. Now, at this point in time, the AV valves are closed and the aortic and pulmonic valves are closed. So as the ventricles contract, there's no movement, no net movement of blood yet, and this is what we call isovolumetric contraction. The ventricles are contracting, but the volume is not changing because the valves are closed. But we're building up pressure because of that ventricular contraction that's occurring. So we build pressure, we build pressure, we build pressure. Ventricular pressure is in this kind of pea green color. And when we build up enough pressure to pop open the semilunar valves, then that's when we see pressure, and they only show us one of the two semilunar valves. They show us pressure in the aorta, okay? So the aorta starts to have pressure build up in it because now we've got blood flow from the left ventricle into the aorta, and so that pressure increases, and we're still building ventricular pressure because we're still contracting, but then as blood volume falls and the ventricles go into diastole, which is ventricular relaxation, we see that pressure falling, and as pressure falls, okay, we've squirted blood into the aorta and into the pulmonary trunk, so that pressure built, but then the pressure's also going to fall in those main arteries, the aorta and the pulmonary trunk. And so the semilunar valves, the aortic and pulmonic valves, are going to close, and you'll notice a kind of a blip that occurs right after they close. And by the way, the semilunar valves closing is that second heart sound, the dub. And then you'll notice there's a little blip of pressure that occurs after those semilunar valves close. That's because after they close, there's just a little bit of backflow of blood in those main vessels, and that's that little blip. But because the valves are closed, it kind of washes back, hits the valves, and then goes along its way. That's why we see the pressure in the aorta start to fall as that blood continues on its path. And arterial walls, okay, the walls of these large blood vessels have smooth muscle within them, so they're going to keep helping to direct that blood in the correct direction. And by the way, that little blip that occurred with the semilunar valves, where you have that little rise in blood pressure, that's also that same little blip that you saw down here with the atria after the AV valves close. A little bit of backwash, and that causes that little bit of rise in pressure in the atria, but then it falls, and then it builds back up as blood comes back into the atria, and then when there's enough blood in the atria, that causes the AV valves to open passively. Okay, so let's move on to the next slide. Let's take a deeper dive into cardiac physiology. We already know that the heart exhibits a property known as autorhythmicity due to specialized cardiac conduction cells, which help keep the heart beating at a regular pace. There are other regulatory controls, including the nervous system, the endocrine system, certain environmental factors, and electrolytes. If we look closely at this slide, you can see how if a person is in homeostasis, the blood pressure for that individual is at a normal range or within a normal range for that person. If blood pressure rises above normal, certain receptors found within the heart, within the walls of the aorta, as well as within the carotid sinus, which is located in the carotid artery, those baroreceptors will be stimulated. It's part of a special reflex response, and when baroreceptors are stimulated by that increase in blood pressure, they will send signals which will in turn cause nerves within the medulla oblongata to be inhibited. So the cardioaccelerator centers in the medulla oblongata are going to receive information from the neurons that make up baroreceptors, and that information is going to be inhibitory for the cardioacceleratory center. And normally the cardioacceleratory center is going to increase the rate of contraction and the force of contraction. But we don't want that to happen if we've got high blood pressure, so those centers will be inhibited, and that helps to decrease cardiac output, which is the amount of blood that the heart puts out from the ventricles every minute. We also see that those baroreceptors, when they're stimulated by the increase in blood pressure, are going to stimulate cardioinhibitory centers. So they're going to send signals that will actually go to cardioinhibitory centers in the medulla oblongata, and that will decrease the heart rate and force of contraction. Again, decreasing cardiac output, helping to reduce blood pressure. And finally, those baroreceptors can send signals to vasomotor centers also located within the medulla oblongata, and that is going to inhibit, because these are going to be inhibited, that's going to inhibit sympathetic signals to blood vessels, so they're no longer constricting as much as they would with sympathetic tone, but they're actually relaxing because we're inhibiting that signal, allowing vasodilation, and that further reduces blood pressure, bringing that individual back to homeostasis. So what happens if blood pressure falls before normal range? Below normal range? Well, that's going to inhibit baroreceptors. And when baroreceptors are inhibited, that inhibition is going to mean that vasomotor centers, which are going to go to blood vessels, are going to be stimulated. So now we're going to send signals to the blood vessels, and that will increase vasoconstriction, which means that it's going to increase blood pressure. Without signals from the baroreceptors, the cardioinhibitory centers are inhibited. They're not going to send any signals if they're not receiving signals from the baroreceptors. And so without the inhibition of the cardioinhibitory centers, which normally would decrease the force and rate of contraction, that can allow an increase in cardiac output and when baroreceptors are inhibited, that's going to allow cardioacceleratory centers to be stimulated. That inhibition actually causes these to depolarize, and so when cardioacceleratory centers are stimulated, that's going to increase the rate and force of contraction of the heart, and that's what helps to increase cardiac output. Since we've been talking about cardiac output, let's define it for you. Cardiac output is defined as the amount of blood pumped by each ventricle per minute, and it's calculated by multiplying heart rate, which is the number of contractions per minute, by stroke volume, which is the amount of blood pumped or ejected by each ventricle. So how do we measure stroke volume? Well, when the ventricles fill up with blood, we have a maximum amount of blood in that ventricle, and that's called the end diastolic volume, because you know the ventricles are going to fill up during ventricular relaxation, which is diastole. So we've got this volume of blood, this end diastolic volume, and when the ventricles contract during systole, even though they contract and eject the blood, there's still a little bit of residual blood left there. And so that is end systolic volume. And we take the end systolic volume and subtract that from the end diastolic volume, and that gives us stroke volume. And they've calculated means for these values. Stroke volume tends to measure between 55 and 100 milliliters, while as heart rate can be anywhere between 60 and 100 beats per minute. And when we look at heart rate times stroke volume, that's what gives us cardiac output. And cardiac output normally can go anywhere between 4 and 8 liters per minute, and on average 5.25. But remember that these calculations are for each ventricle separately, although we tend to look at the left ventricle for clinical purposes. Why? Because that's the ventricle that's going to pump oxygenated blood throughout the body. So that's really important. Not that the right ventricle isn't. It's got to get deoxygenated blood to the lungs for oxygen to come back into the blood with gas exchange. However, normally for clinical purposes, we look at what the left ventricle is doing. Now there's different factors that can affect heart rate, and you already know about autonomic nervous system effects on the heart, hormones, epinephrine, norepinephrine, fitness levels. The stronger and more fit a person is, the more effective his heart works. And age, the older a person gets, the more difficult it is for his heart to work effectively. And then different factors that affect stroke volume include the size of the heart, fitness levels, gender, contractility, the duration of contraction, preload, which is what we call the end diastolic volume, and afterload, which is the resistance. So when blood vessels become stenotic or harder and not as flexible, then that's going to increase resistance or afterload. So again, cardiac output, heart rate times stroke volume. Stroke volume is calculated by taking end systolic volume and subtracting that from end diastolic volume. You always take the larger number, the bigger volume, and then subtract the smaller volume from that. Ejection fraction is the amount of heart ejected from the blood with each contraction, and that is calculated by taking stroke volume and dividing it by the end diastolic volume. And that's normally going to be expressed as a percentage, because you take that value and then multiply it by 100 to obtain a percentage. And the range for ejection fraction is usually between 55 and 70% with a mean of 58. It's often used as a clinical measurement of the function of the heart, and can be measured by a two-dimensional echocardiograph or a right heart catheterization where they actually inject dye into the heart and it fills in the ventricles, and then they actually take x-rays of the left ventricle at different volumes with that dye inside to actually see the volume. And they can also do it with an MRI. Bradycardia is a condition where the heart rate slows down to an abnormally low rate. So it's usually less than 60 beats per minute. And when people have bradycardia, it's usually not a problem unless there are symptoms present. So anything like chest pain, dizziness, lightheadedness, fainting, feeling faint, shortness of breath, fatigue, weakness, memory loss, confusion, getting easily tired during exercise. Those would be some of the symptoms of bradycardia. And an athlete would have a resting heart rate of 60 beats per minute or less simply because his heart is really well conditioned to function, so it doesn't have to beat fast in order to effectively pump blood throughout the body. And what would be causes of things for bradycardia? It's actually something that's common in older people. As they get age, their heart tends to slow down, and there are some cardiac medications like calcium channel blockers, beta blockers, that can cause bradycardia. If a person has an electrolyte deficiency, like not having enough calcium or magnesium or potassium, that can affect heart rate. Even infections like strep can damage the heart and cause it to not beat properly. If the inner lining of the heart muscle becomes inflamed or the pericardial sac becomes inflamed, that can cause bradycardia, as well as some recreational drugs. Marijuana can cause bradycardia. So those are some of the things that can cause it. Now, tachycardia, on the other hand, is a rapid or pounding heartbeat, usually over 100 beats per minute, and is often associated with pregnancy because when a woman is pregnant, her blood volume increases, so because now she's pumping blood not only for herself but for her growing baby, and so she's dealing with a higher blood volume, and she's going to have a higher heart rate that can help her pump blood through her body. So it may or may not occur where it gets to the point of tachycardia with pregnancy. It doesn't happen with every pregnant female, but if it does, as long as it's not super high, it's not considered abnormal. But, you know, just over 100 beats per minute is not generally going to raise an alarm bell for a doctor with a pregnant female. Extreme stress can cause the heart rate to increase and tachycardia to occur, where it's usually a short-lived sympathetic nervous system response. So what could happen with tachycardia? Well, again, a person might feel that rapid pounding heartbeat, might have chest pain, might feel faint or lightheaded again, might feel dizzy, might have shortness of breath, might be sweating, might feel weak, might feel a decreased capacity to exercise. And different factors can contribute to this, including things like heart disease, heart failure, where the heart really has to pump faster because it's not pumping efficiently. It's not getting enough blood out, so it's got to pump harder. High blood pressure, anemia, things like lung disease, hyperthyroidism, inhaled corticosteroids, albuterol. Sometimes when people take albuterol, which is an inhaled corticosteroid, it increases their heart rate because it is a sympathomimetic, and that increases heart rate. And epinephrine pens, EpiPens, will do that as well. Oral methylxanthines can do that as well. Caffeine, alcohol, smoking, illegal drugs, overexerting during exercise. Also, electrolyte imbalances can cause tachycardia, vitamin B12 deficiencies, fever, stress. We already mentioned pregnancy, chronic pain, family histories of tachycardia. These are all things, advanced stage, that can also lead to tachycardia. When a person gets older, his heart may not be beating efficiently, so he may have transient tachycardia. Target heart rate is what people want to achieve when they're exercising. And target heart rate is usually between 120 and 160 beats per minute. So cardiac output is maintained and the person reaches the maximum benefit from exercising. So as heart rate increases from resting heart rate to approximately 120 beats per minute, cardiac output also rises. And between 120 and 160 beats per minute, cardiac output actually starts to decrease as stroke volume falls faster than heart rate rises. So this means that as stroke volume falls as heart rate rises, because the heart is pumping faster, the ventricles don't have time to fill up with as much blood as they normally do. So that's why cardiac output is maintained during that range of 120 to 160 beats per minute. So that's how we explain that in terms of systole and diastole. If the heart is beating faster, that means that the ventricles don't have as much time to fill up with blood and then contract. So stroke volume decreases, but with heart rate rising, we're still maintaining cardiac output. We've already learned about the intrinsic conduction system of the heart. Next, we're going to look at the nerves that innervate the heart, forming cardiovascular innervation. We know that the medulla oblongata is where regulatory centers are located for heart rate and the force of contraction. And these centers within the medulla oblongata are made up by nuclei, which are collections of soma, nerve cell bodies, and their dendrites, which will have an effect on the rate and force of contraction of the heart, which we call autonomic tone. Autonomic tone is basically defined as that constant slight stimulation to the heart, very similar to muscular tone. And again, we're going to take a closer look at these specific centers. We have a cardio accelerator center, which is going to be stimulated when the sympathetic nervous system is stimulated. And that cardio accelerator center has neurons that will project to the lateral horns of gray matter, where there are preganglionic neurons between T1 and T5. And when those neurons are stimulated, they will synapse with postganglionic neurons in the cervical and upper thoracic portion of the sympathetic trunk or sympathetic chain. Those postganglionic neurons, in turn, will form a network or plexus known as the cardiac plexus, which will innervate the SA node, the AV node, the ventricles, as well as coronary arteries. And those axons will release norepinephrine at their terminals, and norepinephrine will bind with beta-1 adrenergic receptors, which are the primary receptors in the heart. And so when those receptors are stimulated, again, that causes an increase in the force of contraction and the heart rate itself. Now, the cardio inhibitory center is actually where the vagus nerves arise, and as they go toward the heart, the right vagus nerve primarily influences the sinoatrial node, the SA node, and the left vagus nerve actually has a greater impact on the AV node and the ventricles. And they release acetylcholine, which in turn will slow down the heart rate and the force of contraction. So again, there's a question on this slide: why does stroke volume decrease as heart rate rises? Well, stroke volume is the blood that's ejected by each ventricle when it contracts, and so if the heart beats faster, the ventricles can't fill up as much, and so they're not going to have as big of a stroke volume when the ventricles contract. So here we can see again that the sympathetic fibers, the postganglionic fibers, are going to end on the SA and AV nodes, as well as the cardiac muscle fibers and coronary arteries, which increases the rate of contraction and the force of contraction. And oddly enough, we would think that the coronary arteries would constrict, because that's what the sympathetic nervous system does to arteries. However, what's kind of unusual is that with the increased metabolic demand, meaning it needs more oxygen, right? That leads to the release of vasodilators like adenosine. And so that the adenosine that's released actually promotes dilation to counteract the norepinephrine, and that causes the coronary arteries to dilate, meeting the increased oxygen demand for the heart muscle so it can continue to beat. And parasympathetic fibers have postganglionic neurons that lie in the ganglia in the wall of the heart, and fibers that act on the SA and AV nodes, which result in a lower rate of contraction and a lower force of contraction. So here we've got some charts. On the left side, you see normal spontaneous depolarization. And then at the top right, you see parasympathetic stimulation, which is really inhibition because we're slowing the heart rate down. And we have sympathetic stimulation where we increase the heart rate. So parasympathetic stimulation, what it's really doing is it's prolonging hyperpolarization and slowing down depolarization, and that's what helps to slow down the heart rate. Whereas sympathetic stimulation does the opposite. It reduces repolarization, the length of time, so it can occur faster, and we also have faster depolarization. Obviously, I had to change locations to continue recording. So this slide deals with visceral receptors and reflexes. Remember that reflexes can occur with skeletal muscle, and they can occur with organs as well. And that's what the term viscera refers to. Visceral means pertaining to an organ, because the term viscera means organ. So visceral receptors include things like the vagus nerve, the cardiac plexus, the baroreceptors, which detect changes in pressure, chemoreceptors, which detect changes in chemicals. We have proprioceptors, which detect changes in motion and position, and the limbic system is also involved in terms of sensory input. So this sensory input for the heart enables the cardioregulatory centers in the medulla oblongata, specifically the cardioaccelerator center and the cardioinhibitory center, to very precisely control heart function. And remember that with increased physical activity, we have increased blood flow, even though we're stimulating the sympathetic nervous system, because for the coronary arteries and for skeletal muscle, there are adenosine receptors that will cause vasodilation instead of vasoconstriction. Normally with a sympathetic nervous response, we'd see vasoconstriction, but for cardiac and skeletal muscle, we actually see vasodilation, and that allows for increased blood flow for skeletal muscles. So let's continue and look more closely at these types of receptors and their actions. So let's talk about baroreceptors, their reflex, and what happens with the atria when there's increase in venous blood flow back to the atria. So there are baroreceptors which detect changes in pressure that are located in the arch of the aorta, in the aortic sinus, in the carotid sinuses, the vena cava, which bring venous blood back to the heart, in pulmonary vessels. And so these baroreceptors will detect changes in pressure. Well, there are also baroreceptors in the atria, and when there's increased blood flow to the atria, because there's an increase in venous blood coming back to the heart, it stretches the walls of the atria, again, stimulating baroreceptors. And if we look at this particular chart on this slide, you'll see that someone is receiving an IV infusion. That causes an increase in pressure in the right atrium, and that stimulates the baroreceptors within the walls of the atrium, and that causes a Bainbridge reflex. So that increase in stretch in the walls of the atrium will send signals to the medulla oblongata, which will increase heart rate. However, what also happens is that because of the increased cardiac output from the Bainbridge reflex, if we look at the bottom of this chart, you'll see that the increased cardiac output causes an increase in arterial pressure. So we had venous blood coming back to the atria causing the Bainbridge reflex, but now we've got the heart pumping out faster, causing an increase in arterial pressure. And the baroreceptors in the blood vessels, particularly the aortic sinus and the carotid sinuses, that detect that change in pressure are going to initiate a baroreceptor reflex. So they send signals to the medulla oblongata, and that actually causes the heart rate to decrease by way of the parasympathetic nervous system. So it helps to balance out what's going on when there's an increase in blood volume. So the sympathetic nervous system is going to be Bainbridge. The parasympathetic nervous system is really being activated by the baroreceptor reflex. Chemoreceptors are special cells that are designed to detect changes in levels of carbon dioxide, free hydrogen ions, lactic acid, and falling levels of oxygen that are often associated with increased activity. If you look at this picture closely, you'll notice that in the neck where the carotid arteries are, there are special groups of chemosensitive cells that make up the carotid bodies. Also, in the arch of the aorta, we have groups of chemosensitive cells that make up what are known as aortic bodies. The cells that are associated with the carotid bodies will send messages back to the medulla oblongata by way of cranial nerve 9, the glossopharyngeal nerve. And those messages, when they go to the medulla, they don't always just go to the cardiac centers, they also go to respiratory centers. And the information that's being carried from the chemosensitive cells in the aortic bodies will travel along cranial nerve 10, the vagus nerve, back to the medulla oblongata, to both the respiratory centers and cardio accelerator centers in the medulla oblongata. So we'll see an increase in heart rate and force of contraction. And also, because signals are going to the respiratory center, we're going to see an increase in the rate and depth of breathing. So when it comes to the limbic system and how emotions might impact heart rate, well, if you've ever seen anyone experiencing anxiety attack or a panic attack, the person may be hyperventilating. And when that happens, it it actually changes both the rate of breathing for the person's breathing very fast but very shallow, and that person's heart rate and blood pressure are going to be going up because that person will be under a sympathetic nervous system response. So there are some charts. Here we have factors that increase heart rate and force of contraction. We've gone over a lot of these different things, and you can see how the effects of catecholamines like epinephrine and norepinephrine will affect the heart. Thyroid hormones will actually increase the effect of epinephrine and norepinephrine. They are going to enhance that effect. Calcium can change the heart rate and contractility. If we have increased calcium, it will increase heart rate and contractility. However, if it gets to be too much, that can also be a problem. If we have decreased calcium, then that can cause tachycardia. If we have decreased sodium, that can cause tachycardia as well. Body temperature can affect heart rate and force of contraction. The higher the body temperature, the higher the heart rate and force of contraction, and different stimulants can do that as well, like nicotine and caffeine. This slide shows us factors that help to decrease heart rate and force of contraction. So when we look at the different things that happen with our proprioceptors, chemoreceptors, baroreceptors, how they're affected, our limbic system, where our parasympathetic nervous system is in control of things, how with the parasympathetic nervous system we're going to have a decrease in catecholamines, epinephrine and norepinephrine, and when there's a decrease in thyroid hormones, that also helps to decrease the heart rate and force of contraction. Decreased calcium will do that. Again, hopefully not dropping too low, because then that causes problems. With increased potassium, that can decrease heart rate and force of contraction by altering the resting membrane potential. Clinically, it is the most important thing to watch out for with a decreasing heart rate and decreasing force of contraction. However, increased sodium, if there's too much sodium, that's going to cause fluid to come back into the blood vessel, so it's going to cause an increase in blood volume, and that actually will cause an increase in heart rate and force of contraction. So if we've got too much sodium, that's that one kind of weird thing that's in this chart. And then body temperature. If there's a decrease in body temperature, that's going to slow down the rate at which the heart beats and the force of contraction. Now, what you can't see because I'm in the picture is how might this be beneficial in a clinical setting. Well, that's why operating rooms are so cold. It's because it helps to decrease heart rate, decrease the force of contraction, and it also slows down the metabolism of the individual while they're operating on a person, and it's easier to control heart rate and respiration rate when they're slowed down rather than when they're operating at a much higher rate. So let's take a look at factors that affect stroke volume. And we know that stroke volume is end diastolic volume minus end systolic volume. And there are three factors that can contribute to stroke volume. Preload, which is the amount of blood at the end of diastole, so it's the same thing as end diastolic volume. Contractility, and afterload. And afterload is the amount of force that the ventricle has to generate when it's contracting to push open the pulmonic and aortic semilunar valves. That's afterload. So how does ventricular filling time affect preload? Well, the more ventricular filling time we have, obviously the more blood we're going to get in the ventricles, so that would increase end diastolic volume or preload. And if there's more blood returning to the atria and then going into the ventricles, well, that's going to increase preload or end diastolic volume. And there's something known as Frank Starling's mechanism or Starling's law of the heart, where the more that comes in, the more that goes out. So the force is directly proportional to the initial length of the muscle fiber. Basically, more in, more out. And when we're at rest, the muscle fibers are not at their optimal length. If you remember from AMP1, there's a sweet spot for skeletal muscle length. So if we look at a range of motion, we get the strongest contraction not at the very end of the length of the muscle, but somewhere there's a percentage where you get the highest force of contraction in the length of the sarcomere. And the same thing is true with myocytes. So if myocytes are stretched more than they would be at rest, so say for instance we start to exercise, that's going to bring more blood back to the heart, and in turn that's going to cause a greater force of contraction because we've got more blood returning to the heart. But remember, as the heart rate increases, well, there's less ventricular filling time, so that only is an initial type of response, because then the heart rate increases and the ventricle can't contract as it can't fill as much as it has when you start exercising. So we said preload, contractility, so the force of contraction, and then afterload. And remember, afterload is that force that it takes to force open the semilunar valves, so the pulmonic and aortic semilunar valves. And in between those valves opening, as the ventricles are contracting, so they filled up in diastole, and when the ventricles start contracting, the atrioventricular valves are going to shut so that the blood, as the ventricles contract, doesn't go back into the atria. So as the ventricles contract, the AV valves are closed, but then the semilunar valves are also closed. And so the volume of blood in the ventricles stays the same, but the ventricles are still contracting, and they call that isovolumetric contraction. So it's building up force. The volume of blood is still the same, but we're building up force because we're contracting enough till we get to afterload, which is the force required to open up the pulmonic and aortic semilunar valves. And so as afterload increases and a person is in that isovolumetric contraction longer, if afterload increases, then stroke volume actually decreases because there's a shorter duration for blood to be ejected from the ventricles. So preload again is just that end volume of blood within the ventricles during diastole. So it's the same as end diastolic volume. Okay, contractility. This is just another slide that's telling us about contractility. It's the force of muscular contraction. So again, that controls stroke volume because the greater the contractility, the higher the stroke volume, and the less the end systolic volume, depending on other factors, because these are so interdependent of one another. So there are things known as positive inotropic factors, which are factors that increase the force of contractility, and there are negative inotropic factors that decrease the force of contractility. So if you look at this particular chart in this slide, you'll notice that sympathetic nervous system excitation is going to positively increase the force of contraction. So that is positively inotropic. Catecholamines, epinephrine, norepinephrine, also going to positively affect the contractility. So they are positive inotropic factors. The heart rate, the faster the heart rate beats, that's going to positively affect contractility as well. So we've got a positive inotropic state with heart rate as well as afterload. The greater the afterload, the greater the force the ventricles have to build up. And so negative inotropic factors include things like parasympathetic activation and systolic failure. So if the ventricles aren't contracting properly or strongly enough, then that's a negative inotropic state. And there are drugs that can affect this as well. And we'll talk about those in a second. So again, what corresponds to sympathetic? Well, greater heart rate, greater force of contraction, positive inotropic. Parasympathetic, slower heart rate, not as strong of a force of contraction, so that's going to be negative inotropic. And the atria have more parasympathetic fibers than the ventricles. So negative inotropes act primarily there, and that decreases the atrial kick or contraction and reduces end diastolic volume, because remember, when blood flows from the atria to the ventricles, 70% flows passively from the atria through the atrioventricular valves to the ventricles, but then that remaining 30% is ejected when the atria contract. So if that atrial contraction is decreased because of the parasympathetic fibers affecting the atria more, that's going to act as a negative inotrope because it reduces end diastolic volume. Okay, so looking more closely at inotropic agents, we've got positive inotropic agents, which include things like dopamine and isoproterenol, which mimic epinephrine and norepinephrine by increasing the influx of calcium. Hypercalcemia, which is having more calcium in the blood, can also be a positive inotropic agent. Digitalis is kind of interesting because it does increase calcium influx. However, it tends to slow the heart rate down by enhancing the effects of the vagus nerve. Then we've got thyroid hormone, which enhances the effects of epinephrine and norepinephrine. There are glucagon receptors in the myocardium that actually also enhance calcium influx. And then we've got negative agents, including hypoxia, which is not enough oxygen in the blood, acidosis, hyperkalemia, too much potassium, beta blockers, calcium channel blockers. These can be negative inotropic agents causing a decreased force and contractility. So again, stroke volume is end diastolic volume minus end systolic volume, and there are three factors: preload, which is end diastolic volume, contractility, and afterload. And afterload, again, is that pressure that the ventricles have to reach to pump against the resistance to pop open the pulmonic and aortic valves. And there's also blood, so there's some vascular resistance in those vessels that they have to make sure that they're creating a greater force than is in the valves and the blood vessels after the valve, so that blood can flow in one direction. So if there's increased resistance, like valvular damage or stenosis of the valve, that would increase the afterload, and that could affect end systolic volume. So we've got this nice little chart here. You can see preload can be increased if there is a fast filling time, if blood is coming in quickly. If there's an increased return in venous blood, that can increase preload, and that in turn will increase end diastolic volume and increase stroke volume. It can also be lowered. Preload can decrease when there's a decrease in thyroid hormones, calcium ions. When potassium ions become too high or too low, it can affect preload. When there's too high or low in sodium ions, that can affect it. If body temperature is low, if there's not enough oxygen, abnormal pH balance, and different drugs like calcium channel blockers, that can decrease end diastolic volume and decrease stroke volume. Contractility can be increased with sympathetic nervous system stimulation, epinephrine and norepinephrine, higher levels of intracellular calcium, higher levels of blood calcium, thyroid hormones, glucagon. And again, if we have contractility raised, that's going to decrease end systolic volume because we're going to get more blood out, and it increases stroke volume because, again, we're getting more blood out. Contractility, if it's decreased because of parasympathetic nervous system, which releases acetylcholine, or in the presence of not enough oxygen, hypoxia, or if we've got too much potassium, if there's a decrease in contractility, then that means that end systolic volume, well, if we don't have enough blood going out of the ventricles, okay, that's going to increase the amount of blood that's left at systole. So it's going to increase end systolic volume, and it decreases stroke volume because we're not pushing out as much blood from the ventricles. And then afterload, if we've got an increase in afterload, that could be due to an increase in vascular resistance, so the amount of blood in the pulmonary trunk, in the aorta, or it could be due to damage of the semilunar valves. If they get stenosed, they don't work as well. And that can increase end systolic volume because we're not pumping out as much blood as we'd like. So we've got too much blood left at the end of systole, and it decreases the amount that's put out, so decreased stroke volume. And then if we have decreased vascular resistance, well, that's going to increase the that's going to increase the blood that goes out. If we have decreased vascular resistance, that means we get blood out of the ventricles. So we're going to have a decrease in end systolic volume and an increase in stroke volume because we're getting rid of that blood. And I believe that's it for the heart. Woohoo! Oh no, there's one more slide. Sorry. Darn. Just almost there, almost there. So again, if we look at the big picture and look at everything affecting heart rate and stroke volume, here's a summary. The different factors that affect heart rate are things like atrial reflex, which is going to be affected by how much venous return is coming into the atria. And that in turn will affect autonomic nervous system, and that will affect the heart rate. So if we have an increased atrial reflex, that will stimulate the heart to beat faster. Hormones can also cause the heart to beat faster or slow down. So those are things that can affect heart rate. And then factors that affect stroke volume, venous return again, the filling time for the ventricles, autonomic innervation, hormones, vasodilation or constriction. Those factors can all affect preload, contractility, and afterload. And so in turn, that will affect end diastolic volume, which we call preload, and systolic volume. And because we take the end systolic volume from the end diastolic volume to figure out what our stroke volume is, that stroke volume times heart rate is what gives us cardiac output. How much blood is being pumped out of the ventricle per minute. That's it, maybe? Yes, this is the very last slide. You made it! Ooh, ooh, ooh. Okay, good job.